Hello, everyone, and welcome to Insights in Public Health Surveillance for Maternal and Newborn Health, which is the fourth of the Surveillance Advances seminar series, co-hosted by the Public Health Agency of Canada and the National Collaborating Centre for Infectious Diseases, or NCCID. My name is Luisa Arroyave, and I'm a postdoctoral fellow at NCCID. I will be your moderator today, along with Louis Wong, who is an acting manager in the Data Surveillance and Foresight branch of the Public Health Agency of Canada. NCCID is funded by the Public Health Agency of Canada to provide knowledge and evidence for use in public health planning, programs, and policies related to infectious diseases. We are incredibly pleased to be co-hosting this series with the agency. I would like to acknowledge that NCCID is hosted by the University of Manitoba on the original lands of Anishinaabe, Ojibwe, Cree, Dakota, and Dene peoples, and on the homeland of the Métis Nation. At NCCID, we strive to honor the lands and their original caretakers in our work. We acknowledge that we are on Treaty 1 land. We recognize that these and other treaties have been implemented as part of the process of colonization, intended to benefit some while harming others. We are committed to working with our partners towards reconciliation. Okay, before we dive into today's seminar, there are a few housekeeping items I would like to mention. A recording of this seminar and presentation slides will be available after the seminar on the NCCID website, which is nccid.ca, under webcasts. The chat box for participants have been disabled for this session, and the hosts will use the chat box to communicate additional information with participants. If you have problems with Zoom during this seminar, please email us at nccid@umanitoba.ca. Also, please send us topic-related questions through the Q&A tab, and we will try to address as many as possible in the discussion period. You can like any of the questions to push them up in priority. We would also like to note that Surveillance Advances is a Section 1 self-approved group learning activity as defined by the Maintenance of Certification Program of the Royal College of Physicians and Surgeons of Canada. The seminar series is also approved by the Council of Professional Experience for Professional Development Hours for members of the Canadian Institute of Public Health Inspectors. If you require a letter of participation, please look out for the survey that we will share after the seminar. Over to you, Luis.
Great. Thank you so much, Louisa, for covering some key housekeeping items. Welcome and thank you for joining us today. Bienvenue et merci de vous joindre à nous aujourd'hui. While today's seminar will be delivered in English, we welcome everyone to pose their question in their language of work. Please feel free to ask your question in English or in French. Ne hésitez pas à poser vos questions en anglais ou en français. I would like to take this time to acknowledge the land where I live and work, located on Treaty 1 territory, the traditional lands of the Anishinaabe, Cree, Ojibwe, Dakota, and Dene peoples, and on the homeland of the Métis Nation. We, the Indigenous people who have lived and cared for these lands for generations, and I'm grateful for the opportunity to share and call this place home. Today, we will have participants and presenters joining us from coast to coast to coast. The land in which they and you join us represent the lived experiences of many Indigenous people, all with their own unique health story. We would like to acknowledge that the practice of public health surveillance may raise concerns for Indigenous peoples and other communities. To public health professionals, surveillance sounds similar to epidemiology, which is about understanding the distribution and patterns of the determinants of health and diseases in populations. But for others, surveillance may carry negative connotations about security, privacy, and control. For this seminar, we would like to note that we use the word surveillance to refer to the assessment and response to public health threats as a core public health function within our health system. This seminar is not just about the speakers or the organizers. It's about you, the audience. Your active participation, questions, and perspectives are vital to the success of this initiative. We encourage you to engage in discussions, ask questions, share your thoughts, and foster collaboration that can lead to improvements in public health surveillance.
Okay. With that assignment, I would like to introduce and welcome our speakers for today's seminar. We have Dr. Anne Sprague. She is a project advisor at the Better Outcomes Registry and Network Ontario, or BORN, where she is conducting COVID-19 surveillance and research investigating maternal and infant mortality and mentoring research and analysis team members. Dr. Sprecht has worked in direct patient care as a regional perinatal coordinator, as the founding scientific manager of Born Ontario, as a researcher and a mentor to many students and team members. We also have Dr. Gillian Alton. She is an epidemiologist at Born Ontario and an investigator with the Children's Hospital of Eastern Ontario Research Institute in Ottawa. Her work at Born focuses on applied public health surveillance and research. Dr. Alton has put her infectious disease surveillance background to use working on COVID-19 and pregnancy surveillance in Ontario and research about COVID-19 vaccination during pregnancy. And we also have Dr. Deshane Fell. She's a perinatal epidemiologist appointed as a professor at the University of Ottawa and as affiliate investigator at the Children's Hospital of Eastern Ontario Research Institute. She uses population databases and registries to better understand factors affecting maternal and infant health, as well as infection and immunization during pregnancy and their relationship with birth and pediatric health outcomes. Dr. Fell served as a member of two technical advisory groups with the World Health Organization to maternal immunization. Welcome, Dr. Sprecht, Dr. Alton, and Dr. Fell. We are really happy to having you today, and we are very excited to learn about your experience and knowledge in maternal newborn health surveillance. The floor is yours.
Thank you. It's Anne Sprague speaking first here, and that's just our title slide, and we'll flip to the next slide, and Deshane will do the disclosures.
Yes, thank you. And thank you for the warm welcome. I just need to disclose that although I am an adjunct professor at the University of Ottawa and affiliate investigator at the Children's Hospital of Eastern Ontario, in the past year, I joined Pfizer as an epidemiologist working on an unrelated topic, but my comments today are all about the research and work that I've done over many years of collaboration with Born Ontario. And so I'm wearing my academic hat today for this presentation. Over to you, Anne.
Thank you. And Gillian and I, neither of us have disclosures. Next slide, please. So the objectives of today's presentation is just to give you a little bit of an overview of Born Ontario. I want to outline our surveillance activities, as I know that's a big interest of this group. And finally, we'll discuss some of the methodological issues associated with surveillance in the maternal newborn population. And I love the comments about surveillance that were made early in the introduction. I think it really is a good understanding of what it is we're doing. Next slide, please. So what is Born, or the Better Outcomes Registry and Network? We are a maternal child registry. We are named in the Personal Health Information Privacy Act in Ontario as a registry, and that allows Born to collect, use, and disclose personal health information without consent for the purpose of facilitating or improving the provision of healthcare. This is a very special place to be and to operate in. But we do have rigorous privacy policies, and they are approved and reviewed and approved every 3 years by the Privacy Commissioners Group. And we can't collect data unless it meets one of the 7 purposes laid out in our privacy and security policy. So we have lots of information and data, but we can't just go grab things we think are interesting. There has to be purposes. So next slide, please. So just to briefly overview this, the Born purposes primarily is to identify individuals or settings where appropriate care has not been received and facilitate access to that care and treatment. We do continuous improvement of healthcare delivery tools, and that really has a lot to do with our prenatal screening arm, where we can tweak our algorithms as needed. We look at where maternal or newborn outcomes are clinically or statistically discrepant from accepted norms and raise alerts when necessary. We can enable healthcare providers to improve care by comparing themselves and their outcomes and performance with their peers or their benchmark groups. Next slide, please. We look at areas where best practice evidence needs implementation. So that's our whole knowledge translation aspect to improve quality and efficiency. Again, it's always about facilitating or improving care to the population. We do a lot of reporting. So we create reports that can be used either by the ministry, by the health networks, by public health units that has timely information to help them. And finally, we can facilitate the provision of healthcare through the pre-population of personal health information on the Born information system. Next slide, please. So we have a lot of data. Ontario has about 38% of the births in Canada. And so where does that data come into Born from? You can see here we have Prenatal Screening Ontario that comes into Born, so all the prenatal screening results. We have IVF cycles from the fertility clinics in the province. We have all the hospital births, most NICU and special care nursery encounters of care. All the midwifery practice groups in Ontario contribute to Born. We have newborn screening results coming in, and the birth centers in the province. And all that fancily gets linked underneath the system. So if you receive prenatal care in one part of the province, but you actually deliver in another part of the province, our linking and matching algorithms will fix that up underneath the system. And we do have a clerk who does nothing but manages all that underneath the system. So right now there's about 1.5 million babies in the system. And so it's great to have data come in, but the most important thing is to give it back to people who can use it meaningfully. And so there are reports, there is a reporting portal in the system. Anybody who puts data in the system can get it out. If you don't contribute, Born has to retrieve it, but we do have mechanisms to help people with that. And there are mechanisms for researchers to be able to ask for de-identified data to do their work. The data comes in either through manual entry or electronic capture, or from hospital information systems. There are ongoing data quality processes, which is, data quality is always important, and it takes a long time to do that work, but it is important. So that's a very brief overview of the system. And now we're going to move on to the next slide. And Jillian's going to talk to us a little bit about surveillance and the work we do.
Thanks, Anne. So building on what Anne had said, one data source or one stream of data may not be enough to answer our surveillance questions. We at Born often use multiple different data sets from different places, and that often includes a complex linkage process using both probabilistic and deterministic linkage strategies. And bringing in all these different data sets requires a large number of data sharing agreements and collaboration among stakeholders and partners. Some other thoughts that we need to keep in mind when doing maternal and child health surveillance is looking at the best data at the best point in time that will be most meaningful. So we're trying not to create extra work for our data entry and trying to grab data where it's already being entered to reduce burden for our stakeholders. And then also thinking about what the surveillance program is meant to convey and how we can spread the word. Because if we're just collecting data and not doing anything with it, that's monitoring and not surveillance. So we also need to share that data and get that out to the people who need to hear it in a timely manner at the time they need to hear it. So one example of this through our COVID surveillance is that we linked data from a variety of different sources. So the Ontario Ministry of Health had PCR testing data for everyone in the province, and that was entered into a provincial database, the Case Contact Management Database. We were able to partner with the Ministry of Health and create data sharing agreements so that we would receive data for people of reproductive age, so that we could link to the Born information system to determine if that COVID positive patient occurred during pregnancy. The COVAX Ontario database had vaccination information for dosage date and the time that was done. So we were also able to get access to this database, cuts of this data, for those of pre-reproductive age, and link that to the Born information system to determine the timing of those vaccinations in relation to pregnancy. And then, of course, our Born information system had maternal newborn outcomes, and we received those in near real time. And our sites were amazing. They were dealing with a pandemic, but also were entering this really critical data for us in a timely manner. And that made our work so much easier. So by linking all of these different databases together, we were only then able to get a full picture of what was happening with COVID and COVID vaccination in pregnancy. And we were then able to communicate that, assemble reports and different dissemination activities, and communicate that to our stakeholders, so the public, our healthcare providers, our funders, and different government agencies. Next slide, please. And surveillance in pregnancy can be tricky. So in best cases, pregnancies last around 39, 40 weeks, but exposures can happen at different time periods and can have differing effects. And so we need to be considerate of these in our analyses. So with pregnancy surveillance, just generally speaking, we have to have enough time to study the outcomes. So pregnancy lasts 39 plus weeks. So sometimes we need to think about in studies or grants that are available that time period. So sometimes grants are 1 or 2 years, and that does not give us a lot of time to gather all the outcomes necessarily for the length of a pregnancy. So it takes some time to get enough data into the system to be able to look at trends that are happening. So it's something to keep in mind when doing any surveillance in pregnancy. And then also thinking about just normal lags in data within a registry. So as well as our data gets entered by our there are some lags that happen. And you need to keep that in mind when considering your data reporting requirements. And then there's also methodological considerations. So some of these complexities of pregnancy also have an impact on methodological processes that we do with pregnancy surveillance. So there's time varying exposures that occur throughout pregnancy, as well as fixed cohort bias that you need to keep in mind. Next slide, please. And I will, so some examples of ongoing surveillance at Born. These are just a few examples of some of the things that we regularly are looking at. So we have a live dashboard from all hospitals contributing data, and there are 6 KPIs that are a group of stakeholders develop, and there are set benchmarks based on the literature, and there's a dashboard with signals, so red, yellow, and green signals as demonstrated as depicted on the screen. That can help our hospitals look at areas that they might be able to work on to improve care. We do newborn screening surveillance. So there are newborn screening for certain illnesses that are done at birth, and they're very important because they are treatable if we know about them. They are quite rare, but definitely treatable and can be very serious if they are missed. So the board information system is involved with Newborn Screening Ontario to have alerts to hospitals and practitioners of babies that may have had this screen missed. We also do prenatal screening. So there's various projects with nuchal translucency, quality assurance, and surveillance of positive and negative tests to tweak regular algorithms to help improve the care provided to pregnant individuals in Ontario. We're also doing have some ongoing projects on maternal mortality, which is linking various data sets to measure and report and compare on maternal mortality rates in the province, and then as well as looking at infant mortality and linking of data sets to look at the infant mortality rates. Next slide, please. And I will turn this over to Anne to talk a little bit more in depth about our maternal mortality surveillance.
So I wanted to say a few words about this because it was highlighted within your group as something you were interested in. So you may know that in developed countries, much of maternal mortality is preventable. And traditionally, it's defined as death up to 42 days post-delivery, but the UK, United Kingdom group, and others have demonstrated the importance of looking out to 1 year post-delivery to really pick up on mental health and substance use issues that can be tied to pregnancy and birth that may have not been as easily identified if you only looked at early mortality. In Ontario, the coroner reviews most maternal deaths, but they don't always know if someone has been pregnant within the last year. This group issues reports with recommendations, but they don't have currently have a real good, robust KT strategy or a feedback loop. So their reports and their recommendations are out there, but we don't know if they're being followed. BORN is currently working with the coroner's group to try and improve surveillance, and our ultimate goal is to facilitate and improve care and prevent maternal deaths. Next slide. So BORN Group, we are currently analyzing 20 years of linked Kai-Hi Dad, Kai-Hi Knackers, and BORN information system on maternal deaths. We're in the process of doing that right now. We have a large interdisciplinary group who are feeding into us their expertise on this. Right now, we are reviewing all the diagnosis codes, intervention codes, and birth and death information, and there's a group of 3 clinicians who are determining what the most likely cause of death was and whether it was obstetric related and possibly preventable. So this project is a first step. There's much more to do. It's being repeated throughout. Some of the provinces in Canada have maternal mortality review groups, and the SOGC, Society of Obstetricians and Gynecologists of Canada, is currently leading a process to help those provinces that don't have review processes get on the bandwagon and get this started, because there's no reason that a death in Ontario that has the same etiology as a death in Alberta, that we should have to keep making the same kind of mistakes. So we're working together across the country to try and do a little bit more about maternal mortality surveillance. So you could check out the SOGC website if you're interested more in that. Next slide, and I'll turn it over.
And I think you were still going to, yeah.
Okay, sorry, infectious. Okay, so before I turn it over to Shane, BORN also takes part in infectious disease surveillance. And so we've, over the years, have been involved in a number of different ones. Deshane and I lived through 2009 H1N1, and we looked at both illness, vaccination, and medications, and Deshane's going to touch on that. We did do a lot with COVID-19 surveillance, and although our data collection has just finished, we're not quite finished with all our manuscript work, but we did look at both illness and vaccination. RSV, as you all know, is a hot topic right now. We're not doing much with that yet, but the advocacy work is ongoing, and I just got off a national call where they were discussing the new recommendations for that. Syphilis and congenital syphilis is another big area. There's illness data available, but it's not robust. We're partnering with a pan-Canadian group again to do more about that. Group B streptococcus, the vaccine is on the horizon for that, so we'll want to do some work with that. We haven't really, we do collect information on the illness for sure. And cytomegalovirus, newborn screening. Ontario recently added this to their panel, so surveillance is possible. So there's a lot to do in infectious disease surveillance, and I'll go to the next slide.
Thanks, Anne. So I'll jump in now and talk about a couple of applied examples of pandemic surveillance work that we did. And as Anne mentioned, we were both employed at BORN Ontario actually during the 2009 H1N1 pandemic. In fact, this was probably one of the first things I had to do when I joined BORN as an epidemiologist in 2009. I was previous to that at the Public Health Agency of Canada. And so H1N1 had already started, the pandemic had started. And by the time I joined BORN, we knew that there was a higher disease burden in pregnant people than in similarly aged non-pregnant adults, which is not unusual in the case of respiratory illnesses. So we had a big job to try and implement some enhanced surveillance within the database that existed at that time, which was an older version compared with what BORN has now. Back then, everything was, a lot of the data that came into BORN Ontario was manually entered, so it was less automated than it is presently. And so it was quite a bit of work. So we ended up working with over 100 hospitals across Ontario to implement kind of a paper-based data collection strategy that eventually was inputted into the provincial database, which was a tremendous amount of work, but we had incredible participation by healthcare providers across the province who were extremely concerned about the health of pregnant people and their infants, and really worked hard to help collect these data. So next slide, please. So we, in a short amount of time, we did somehow manage to put that process into place. And as I mentioned, had great participation on the part of healthcare providers across the province. And we have actually been doing a lot of studies with those data. We're still doing one more study at the moment, but in that time period, we, as Anne mentioned, looked at influenza vaccination, H1N1 vaccination in pregnancy. And in that first publication there, you can see that was published in the American Journal of Public Health about pregnancy and fetal outcomes. And that was one of the first studies that was published actually about the use of pandemic vaccine in pregnant people at that time. And there are many other studies followed. But we were able to use the data that we collected to look at coverage in the pregnant population in the province. We looked at safety outcomes after both vaccination and use of antiviral medication in pregnant people. And then we actually took the born information system, and we were able to, with of course all the appropriate data sharing permissions, we were able to transfer those data to ICES here in Ontario, where we were able to link the born information system with many other health administrative databases in Ontario so that we could follow the health of the babies after birth, and comparing babies born to vaccinated and unvaccinated pregnant people. And so I've just shown a couple of the studies that we did to look up to the first year of life, and then we subsequently published out to up to the age of 5, looking at various outcomes. And at the moment, we're doing probably one last study now following these children up to the age of 10 and looking at autoimmune outcomes. And as you know from the COVID-19 pandemic, a big concern in the early days when we first prioritized the COVID-19 vaccines for pregnant people was safety in the short term, but also in the long term. I think a lot of people really started talking about longer term potential effects of vaccination in pregnancy. And fortunately, we had been doing quite a bit of work in this area already, which was extremely informative at that time. Next slide, please. And then came COVID-19. So, even though we now had H1N1 under our belts and the experience from the work we did during that time, and a new and improved database with Born Ontario, there were still a lot of challenges that we had. And in fact, Gillian, Anne, and I worked closely and very long hours in the early months in 2020 to try and come up with a strategy initially for collecting information on COVID-19 disease in pregnant people. And as Gillian already mentioned, I think at the beginning, there was really no way we could just link information into the born information system to look at outcomes in pregnant people who were infected with SARS-CoV-2. So we, again, kind of began with somewhat of a paper-based approach, a case report form that hospitals filled in when there were pregnant people admitted with COVID-19. But eventually with the CCM database that Gillian already mentioned through the Ministry of Health, we were then able to take a more automated approach, which really improved the scope of what we were able to do and the completeness of the surveillance that we were able to do as well. Because when we were relying on the case report forms, we were certainly only ascertaining, a percentage of all of the cases and probably the most severe cases, which is important. But once we linked with CCM, we saw, in fact, there were many more people who had COVID-19 in pregnancy. And so we were able to look at those outcomes and contribute to the national surveillance as well through Can COVID Preg. Again, Gillian already mentioned that eventually, once there were COVID-19 vaccines, we were able to then again get permission through the Ministry of Health and obtain regular cuts of the COVAX-ON database. And so we were able to, once again, identify people who got vaccinated during pregnancy. And as Jillian also mentioned, it's really important to know, when in pregnancy, the number of doses during pregnancy, and so on. And so we were able to link those data into the system. But it was very challenging despite being automated. So it seems like that would be easier, and it's certainly more complete, but these are very large databases. And typically with the born information system, it's usually, in the past at least, wasn't really used in what I would call kind of real time. So, records come into the system from all of these various contributors, as you've already heard about from Anne. But usually Born as an organization would wait for some time to pass, ensure that all of the records have come in, go through a very comprehensive process of data cleaning and validation and so on, before then having a data set that would be considered fit for use, for surveillance or for research purposes. In this case, because of the urgency of the situation, we pushed the registry in a new direction, and we were kind of linking these data sets on a monthly basis in near real time. And again, as I think Jillian already alluded to, the contributors, the data contributors across the hospitals and midwifery practice groups and birth centers in Ontario were really incredible in ensuring that the data was coming in on pregnant patients from their facilities in a very timely manner, which allowed us to then do very contemporaneous studies, both surveillance studies as well as actual research studies as well, once there were a sufficient number of people who had been vaccinated. Next slide, please. So I think we've mostly covered this between Jillian's earlier comments and my comments just now, but essentially, as I said, we used real-time data from the registry. And so this was a combination of both of using not only what we call the birth record, so the completed pregnancy, so that we could look at the outcomes of the pregnancy, both from the maternal perspective, but also in terms of the newborn. But we also use the prenatal screening data. So Jillian and Anne both mentioned Prenatal Screening Ontario. And so from those records, we were able to also identify in near real time who was currently pregnant in the province of Ontario. And so that really allowed us to see how many people were receiving COVID-19 vaccine, what was the coverage in this population, which was a high priority population. As of the spring of 2021, when it became clear just how increased the risk of severe disease was in people who were pregnant. And so I think the other databases we've already mentioned, but essentially we were linking all of these sources for quite a long time on a monthly basis. And eventually, as things started to kind of wind down with the pandemic, we slowed the cycle of that work. Next slide, please. So as Anne mentioned, for COVID-19, we focused in both on looking at risk of COVID disease in pregnancy and impacts on the maternal newborn healthcare system in the province. And then in a moment, I'll show you some of the work that we did on vaccination as well. So number one there on the left is just kind of a snapshot of some data that are available on the Born Ontario website. So we did in the beginning start producing some short surveillance reports with just high level numbers about the number of pregnant people who had SARS-CoV-2 infection in pregnancy. And then eventually, as surveillance initiatives nationally were established, then focused on ensuring the Ontario data were contributing to that national surveillance initiative. And so number 3 is actually showing one of the manuscripts that was eventually published out of the CAN COVID national PREG team, which was supported by FAC actually. And then number 2 is one of the research studies that we did to look at changes in healthcare that was received by pregnant people in the first wave, so the very early months of the pandemic, because there was, as I'm sure everyone knows from just reading the newspaper, there were so many articles about people who had to give birth without their partners or other supportive people with them to support them through the labor and birth. Just so many changes in the way that pregnant people were receiving care, both during pregnancy as well as at the time of delivery. So we looked at some of those health system changes. And next slide, please. And then the vaccination in pregnancy, we did a tremendous amount of work on this. And this was work that was supported by the COVID-19 Immunity Task Force. And so we, as I mentioned, all of the databases that we were able to link together in Ontario, and I think this was quite relatively unique in the world. There are not too many places, even today with the advancement of databases and so on, that truly have full population coverage of the maternal newborn population and can kind of link to other things like vaccination status and in near real time to be able to look at outcomes. So this was, I think, really important work that a large group of us were very busy with for about 2 years. Number one shown there is just a screenshot of one of the surveillance reports that we did. I think we published about 7 of these reports. I think they're archived still on the Born Ontario website, but we not only put them on the Born website, but we really developed a very comprehensive knowledge translation strategy and ensured that these were shared very widely with care providers, public health officials, nationally, provincially, and municipally. And to make sure the information was getting to people who really needed it in real time. So that was the surveillance arm, but then we have undertaken a number of studies. This isn't all of them, but I think these are some of our more important ones. Number 2 was the first true research paper that we published based on this work. And this was, I think, the largest study that was published at that time in March 2022. And this was published in the Journal of the American Medical Association. And was a really important study that has subsequently been cited a lot, where we looked at many different outcomes around the time of the birth and didn't see any associations with adverse outcomes and vaccination in pregnancy. And then we subsequently, as we had more information in the system, we were able to then move on to the third study, which is where we looked at some of the really important outcomes in the maternal newborn population, looking at preterm birth and small for gestational age birth and stillbirth. But you can't do those studies until you have a sufficient number of people in the system who've been exposed to whatever exposure it is that you're interested in this case, vaccination. So that one came a bit later. And then subsequently, we've done quite a few coverage studies, and then one study, number 5, was a safety study that we did looking at the first booster dose, so dose 3 in pregnant people in the province. Next slide. This is my final slide. Sorry if I'm taking too long. So just I wanted to share a few learnings thinking about pandemics, because in both cases, from H1N1 and COVID-19, it was heavy lifting no matter what you do and what your resources are. It was difficult to get this work done. I think obviously we were in a better position with COVID-19 because we were, for the most part, more able to rely on routinely collected data that were already coming into the system and then being able to link databases. This is such a huge strength of having these kinds of systems. And as a result, we had much more real-time data. So our studies, we were able to do our safety studies much faster in COVID-19 than we were in H1N1. So I think there are a number of strengths of the current system, the current state that we have here in Ontario, at least with the Born Ontario Registry, for thinking about infectious disease surveillance, particularly in the context of an outbreak or a pandemic. Obviously, as Anne and Gillian have told you, Born Ontario is very comprehensive. It's province-wide. Information is collected about all of the pregnancies and births in the province across different locations of care. And the information is very comprehensive. It's a very rich source of information about clinical characteristics and outcomes and so on. As I mentioned, the data are now also very timely, and we really demonstrated that in the COVID-19 pandemic. We, again, through the linkages that we're able to do with other sources of data, we can also then, after the time of birth, use the birth registry linked with those other sources to look at longer term health outcomes, both in mothers and in babies, and not just after infection or immunization, but after any type of exposure in pregnancy. I've already talked about coverage and linkages. So just some of the challenges I think that we still face, even now with this beautiful birth registry. It's very difficult to ascertain pregnancies that are lost before 20 weeks of gestation. So either through a miscarriage or other event. And this is not unique to Born Ontario. This is very difficult everywhere. So that is a gap and a challenge that I think we're always searching for solutions. We can use administrative databases as well to conduct surveillance in the maternal newborn population, and certainly we do that both provincially and nationally in Canada. But those types of data sources do have some limitations on the richness of the data compared with the birth registry. In thinking about vaccination studies specifically, this can be challenging in Ontario and elsewhere because often we don't have necessarily a complete source of vaccination. So in the case of H1N1, for instance, we collected those data on paper. Thankfully, with COVID-19, we were able to make use of the COVID-19 registry. And then another issue I think that really was a challenge both in H1N1 and in COVID-19 is that it's just so difficult to share data across provinces and territories, and yet it's so important, I think, in the context of a pandemic, when you really need to get national level data and understand what's happening in this population. And then just finally, again, in a pandemic, you really need highly trained personnel, data analysts, epidemiologists, and so on to handle this work, this complex epidemiological work, but also just the data linkages and data management, which is quite challenging. And so finding those people in an emergency is quite difficult. So I'm going to stop talking now and hand it back over to Jillian, I think. Thanks.
Thanks to Shane. So next slide, please. So just to wrap up, I'm just going to talk a little bit about some of the surveillance that we have on the horizon at Born. So I think Anne mentioned this, that syphilis rates have been increasing drastically among women in Canada. And it's something that is of concern, and it varies across Canada. But overall, the Canadian rate of congenital syphilis is estimated to be about 26 cases per 100,000, which is significantly higher than rates in other countries. For example, the European rate is 1.9 cases per 100,000. So it's definitely something we are looking into. There is limited surveillance data that's available right now, and that's limiting our ability to best inform strategies for the prenatal population, but it's something we're advocating for and actively looking into. And I'm hoping that we will have some solutions and data to share with you at some point in the future. Next slide, please. And then the other one is RSV surveillance. So the vaccine has been licensed for use in pregnancy by Health Canada just this past January. So I understand that NACI recommendations are to be coming out shortly. And that will also help give us a bit of an idea. But given that the idea is that it's be given to the mother during pregnancy to prevent RSV in newborns, which is the major cause of hospitalizations in newborns, as well as morbidity and mortality. But we need further population level surveillance for this. We have yet to find a reliable source of data right now because as I understand the vaccine, it will not start out to be publicly funded. So there's no set registry or easy data sources to leverage at this point. But we are doing our advocacy work and getting our partners and our stakeholders together to solidify this message and advocate for this. So I'm hoping that this RSV surveillance does does come to fruition, and we have some great data to look at in the near future. Next slide, please. And then what does surveillance success look like? So from our experience at Born, we need meaningful information that can help to impact change. So we want to, our goal at Born is always to facilitate and improve care. So we take the data, again, not just monitoring data, but we take that data and we feed it back to those who need to know. So to inform decision makers and funders, those who receive care, as well as our care providers to help advocate and facilitate and improve care. Communicating that message is and the information is so important. We have a whole team dedicated to knowledge translation and getting that right message out in the right format at the right time to the right people. And that's a huge part of making your surveillance system a success, as well as partnerships. So we spend a ton of time at Born nurturing our partnerships and our stakeholders because not one group or person has the ability to do all of this. It takes a lot of collaboration from many people and getting those people together to talk and to develop these really brilliant ideas that come out of these talks. So these are all the key components that will make surveillance a success. Next slide, please. And then just to wrap up, there's a few websites that you can check out for more information on Born Ontario. If you're interested in requesting any data, as well as some of our information that we have currently on our website on some of our surveillance outcomes for COVID-19. And I will turn it over to questions now.
Great. Thank you so much, Dr. Sprague, Alton, and Fell, for your very insightful presentation. Lots of great information here. And I think a couple of things kind of jumped out to me, specifically around the need for skilled personnel. And it's not just in the analysis side of things. I think, Dr. Alton, you towards the end, you highlighted the need to ensure that the information is reaching those who can use it and act on it. So hearing about the robust KT team to kind of ensure that that messaging is getting out there really spoke to me. So I'm going to turn it over to you being the participants, and questions are coming in hot. So I'm going to start with the first question, and that is around database data on newborn and infant mortality include. So the question is, does the database data on newborn and infant mortality include deaths, both in the hospital and out of hospital? I was wondering, especially around newborns, with regards to early onset sepsis, which could occur out of hospital. So maybe I'll pass that over to you, Dr. Sprague.
Yes, I answered that question. So I'll just summarize what I said. Born has maternal mortality and infant mortality data in the system, but we like to use both Born and CIHI linked data to ensure we get the good ascertainment that we need. Born right now is only active in the obstetric units in hospitals and birth centers. Therefore, if we didn't use CIHI data and link, we would exclude people who died in the ICU and emergency rooms, or those who are transported into a hospital in a very serious condition. So that's the linkage that we need to do to make sure our ascertainment is good. There was a subsequent question about how you might capture deaths that occur outside of hospitals. And I think we probably have, we are working with a coroner group in Ontario, and all of you in your provinces, either coroner or medical examiners, you probably need to partner with them to review those deaths. In Ontario, the coroner has a pretty good database, and we just worked with a student who looked at that database and was able to have some good information about deaths. So I think that speaks to the importance of partnerships.
Great, thank you so much, Dr. Sprague. The next question revolves around sharing data with community partners. So how are data or results shared with Indigenous communities and partner organizations? How do you deal with small sample sizes and balance the rights to access with privacy concerns that are often cited as the reason for limiting access?
I can start. Jillian and Deshane can add in. It is a problem. Small cell sizes, of course, are important. So we certainly have policies at Born as to how to prevent the inadvertent disclosure or in being able to de-identify data. And what was the second part of that question? It was about.
How do you deal with small sample size and balance the rights to access with privacy concerns?
Yeah, so that is important. So in our system, in the Born information system, as I mentioned earlier, people who contribute the data can get their own data back, but that doesn't help. So they can look at their own small cell sizes, but at the provincial level, we can't disclose small cell sizes except in extraordinary circumstances, in which case we need a waiver for our privacy rules, etc. Jillian, do you have anything to add to that?
I'll just add that there is, I forget the exact name of the group, but there is a Indigenous data governance group at Born that is either in the process or have developed. I'm not exactly sure on the status of it, but we're working on a set of governance guidelines to help with Indigenous communities that wish to access their data and use it in an appropriate manner and interpreting it correctly. So that is underway.
Great, thank you. And then the next question is, can you share how you use Born for surveillance of breastfeeding and other BFI statistics?
I can tell you that Born has a report specifically built in the system for surveillance of breastfeeding that goes along with the BFI recommendations for how breastfeeding outcomes are to be reported. So that is live in the Born information system, and the users can print that out. Subsequently, we could also, for people who wanted to request that type of data, we have it built so that we could extract it by the BFI group definitions. Jillian, anything to add to that?
I'll just add that currently Born only collects data up until discharge from hospital for breastfeeding surveillance, and then public health units move on from there in Ontario to collect longer term breastfeeding.
Great, thank you so much. And I can see Dr. Fell's typing in a response to one of the other questions. So maybe I'll pose the next question to the group is, can you please confirm if Born monitors newborn congenital anomalies?
Yes, we do. We contribute data to the National Congenital Anomalies Surveillance effort that happens through FAC. And so we do collect them. Of course, always it's a problem with data quality and ascertainment because some of them aren't, like Jillian said, Born only sort of ends at time of hospital discharge, except for midwifery clients who see their patients their clients up to 6 weeks postpartum. But so some of those congenital anomalies don't show up right away. So, we have some of them, and we do contribute nationally to that. So, Jillian, anything to add to that, or Deshane?
No, I think that covers it, Anne.
Okay.
Great, and I think we're going to end with one last question, which is, have you done any work on perinatal mental health surveillance?
I can start. So we do collect mental health data in the Born information system. Through a pick list, there's a series of mental health conditions: anxiety, depression, previous depression, bipolar, schizophrenia. Those sorts of diagnoses are there that people, when they're asked, will self-report. So we do have the ability to report out on that. We have reported, in previous reports about the number of people who have mental health conditions in pregnancy. Certainly, I think there's been a couple students who have requested data to do some mental health work. Jillian, do you know anything more from that?
No, other than we do collect data from the Healthy Baby, Healthy Children program as well. So there's a bit of information on there related to mental health on that postpartum screen. So there has been some work looking at that as well.
Great, thank you. And I know I said that that was going to be the last question, but there's actually a really good one that just came in. So I'm going to pose this last one, then I'm going to pass it back to Louisa. The question is, are priority populations in those who are disproportionately impacted in order to help with data interpretation to ensure reduction in stigma, particularly for issues related around congenital syphilis, drug use, and perinatal outcomes?
It's a really good question. So are we consulting with the people, or it's a question about?
I mean, it could also be whether or not you're engaging with individuals from which the data is collected from to support the interpretation of the findings.
So we have a coordinator group across the province of Ontario, and that coordinator group meets with the populations from whom we collect data. And we certainly also have, as Jillian mentioned, an Indigenous coordinator. So, you know, I would say, do we do it to the best of our ability? Probably not. But we are learning and growing as we go along, sort of that, you know, the nothing about me without me sort of principle that people talk about. We're trying to make sure that we do consult and have work in that area. And we certainly have a health equity group that is very active at Bourne, looking at those issues about people who are either materially or economically disadvantaged or racially disadvantaged, depending on what the situation is. So I don't know, Jillian, do you want to add anything else to that?
I'll just say that a lot of our reports are we use stakeholder engagement, so not necessarily our end users, but stakeholders who do engage with those particular groups, practitioners, and we do engage with them in developing reports that are meaningful for them so that they can get it, disseminate that information to their
Bourne's
patients
clients
as well.
are primarily the people who provide us with data, which are, you know, healthcare providers, hospitals, etc. But we do have an app called OMAMA, which is a pregnancy information app, and we do work with stakeholder groups in terms of developing content for that. So that's another way that we get at those issues.
Great. Thank you so much for your thoughtful responses, and thank you everyone for your wonderful questions. Louisa, back to you.
We are approaching the end.
Oh, I think Louisa paused, so I think she was just thanking everyone for your wonderful participation. Oh,
Can you hear
there
me
she
now?
is. Yes.
Okay, I'm so sorry. So just saying thank you, our speakers, for sharing their insights and expertise, and of course for this great presentation, and of course thank you all of you for joining us today for this seminar, and we hope you enjoyed. Please take some time to complete our survey for this presentation. You can scan the QR code on this slide to access the survey, or look for the link in an email that we'll share with you. Your feedback is very important to help us to identify areas of success and improvement for this series. And you will also be able to request a letter of participation at the end of the survey. A reminder that the recording for today's seminar and presentation material will be accessible for viewing on NCCAD website in a few weeks. And if you have more questions about the Surveillance Advances seminar series, please visit NCCAD's website. Our next seminar will be held on Tuesday, February 27th. And that concludes today's seminar. Thank you all for joining us, and see you in February.